No, we're out. Here, John and I can share.
So in past years, I have handled this session on my own and have been able to offer some general information. This year, I wanted to upgrade that a little bit, so I have invited Dr. Adam Schlichting to be here among us, medical doctor, master of public health. Some of you have probably pieced together already based on the name, and now that you can see his picture up there, yes, he is my brother, and as long as I have been alive, his hope was to be a doctor, and now he is one. Did residency at Henry Ford Hospital in Detroit, which we drive by almost every day on the mission trip. Worked at the University of Iowa in intensive care there, and currently in Milwaukee at the Advocate Aurora Medical System up there. And specializes in critical care, both emergency department as well as ICU. Anything else you want to add on to that?
Nope, that was fantastic. Thank you.
Very good. So we are going to forego section 1 right here on the handout, and I will just encourage you, if you want to check those out at your leisure. The point I wanted to make with those scripture citations is there's a lot of church folks who are still kind of the opinion that, well, whatever happens now, whatever happens with our bodies, that's not what matters. It's what happens to our souls. You are going to have to search far and wide and do some really complex cutting and pasting to find that in your Bible. What does God say when God makes all the physical stuff in the world in Genesis? God looks at it and God says, "This is good." The gospel writers are very in your face about Jesus is not an apparition. This is not about his soul. His body is transformed, but he is resurrected. Jesus spends his whole ministry healing people, feeding people, improving their life. And of course, John's gospel talks about the word became flesh and lived among us. That matters. That's how much all of this good creation God made matters to God. So the notion that, well, your body is just a tomb for your soul until you die, and then your soul gets to be free. That's all Greek philosophy that has worked its way in. Scripture wants us to take stewardship of our bodies seriously. That includes our health. Talking about our physical health and well-being is absolutely something that is right on target for us at church. These are probably not, as I've said before, these are probably not conversations you would just get up in the morning and, whoever it is you talk to, first person you talk to in the day, say, you know what I want to talk about today? If I'm in the ICU, I want you to do. And as we've said, it's better to have that conversation now than when everybody's in a moment of crisis. And if you need a little extra push to start these conversations, and I realize at some point this reference is going to be dated, but I think everybody here will remember it. If you need a little push to say, I should really get some plans in place, I have 2 words for you. Terry Schiavo. Do we remember Terry Schiavo?
Wow, blast from the past.
She was in a vegetative state, but also in the midst of a divorce. Her husband wanted to pull the plug, but since he was still a husband, he had authority, but the family filed a lawsuit. The US Congress got involved. I mean, it was
a mess.
It was a mess. Whatever your wishes are in terms of what kind of care you want, you don't want the mess. If you are the person, you're like, you don't even have to pull the plug. Don't even plug it in the first place. Yeah. That's your choice. If you want to say, I want you to do everything possible, that's your choice. But you want people to know that. So let me go ahead and let me turn it over to you.
All right. Well, I think as Eric was just mentioning, this is not the most uplifting and fun topic to discuss. So we're going to try to keep it a little bit lighter as best as possible. Let me see if I can change slides here. 1 second. How do I advance? Oh, there we go. So biggest purpose of today is just to have everyone participating become a little more educated of a consumer. What are these aspects of healthcare? What are things that you can do to sort of spell out your wishes? It doesn't need to be the same today as it was a decade ago, and it doesn't need to be the same decisions that you'd make for your healthcare a decade from now. And then once you've sort of determined what's best for you, who should you share this information with? How should you share this information? Again, largely to avoid a lot of conflict towards the end of life. This is certainly not a sermon. So if anyone has questions as we go along, I can't see if people raise their hands necessarily, but just go ahead and shout out your questions. This is all information that I deal with every day, so I know this stuff. If there's anything that I go over that you're not quite clear on, certainly ask. That's why we're doing this today. Now, has anyone seen the movie Titanic? Is anyone surprised by how that movie ends? The boat sinks. Similar with life, your mortal life will end, 100% guarantee. This is, the whole premise of Christianity is death and resurrection. It's not surviving forever, not immortality of the body. It's death and resurrection. Resuscitation that we'll talk about in medicine. Resuscitation temporarily restores life or temporarily continues life. It's not the same as resurrection. And I think Eric, when we were discussing this and what he wanted me to focus on, he gave the explanation of Good Friday always comes before Easter. There will always be death preceding resurrection. And if you don't believe me, it says so in the Bible. People are destined to die. Many other examples of you will lose your life. Again, not to be too much of a downer, but we all know it's coming. For us, for our children, for everyone, death will happen. So we make some preparations for that. I think I've hit that point home pretty well there, huh? Everyone's going to die. So it is simply the end part of life, and we know it's going to happen. There's things we can do that can delay that, things like CPR. If you do CPR on someone, sometimes they can actually survive years and years and decades longer. And sometimes it's a mere second or a few minutes longer. So there are things we can do that delay the dying process, but it doesn't prevent it. So accepting that, I think, is so important. There are so many choices that can go into what you want or what you don't want. CPR versus not CPR, a do not resuscitate order, or a out of hospital do not resuscitate order. All sorts of different aspects of life support. We'll go into a little bit more details on those things. Some of the forms that Pastor Eric will share with you, those forms you can actually specify yes or no. I want this, I don't want this. I want this part and not this part. And the Indiana forms, they're legal documents. We'll go over those, but you can actually say a lot of the, aspects of your care that you don't want. So going into life support, just as a background, if we have any healthcare providers in the room now, certainly feel free to chime in. Any questions thus far?
I was gonna say, I know we have at least three nurses in the room this morning.
And I'm in administration.
And a healthcare administrator.
Excellent. So during any of these talks, feel free to chime in. This is sort of a cursory quick view of different types of life support. So I don't want to go into too much detail. Don't get lost in the weeds, but some of the terms that you may hear of, just to kind of briefly cover them here. So life support is different stuff we can do. It's using equipment or treatments or medicines that temporarily replace the function of the organs of the body. And the whole intention of life support is to give time. It buys us time. It buys us time for those antibiotics to kick in and fight off the pneumonia. But if your lungs aren't working during that time, you can be on a breathing machine, and the breathing machine supports your lungs. Or if the kidneys shut down because of a bad infection, we've got renal replacement things we can do, like dialysis. And sometimes that's just short term, but it can replace the function of the body or parts of the body that let those antibiotics work, or that let those treatments work. So life support by itself, I think, is fantastic. It gives us more time, and the body takes time to heal. So it provides for that. As a destination, though, maybe being on life support for the rest of your life, if it's not a good quality of life, is something that you may not want. If it's a young child, if we provide very aggressive life support to someone and they recover and they get better and go on to live a fulfilling life, fantastic. That's what life support is designed for. If someone's 110 years old and has a, devastating neurologic problem or a huge stroke, perhaps putting them on life support right at the end of their life is not the right thing to do. So these are all things to kind of think about. So as far as different organ systems we can support. So for the lungs, mechanical ventilation. Some of you may use CPAP machines at home or BiPAP machines at home. It's a tight mask that fits over your face, blows air into the lungs. Long term, that's not really a form of life support. It helps with sleep apnea and things like that. But in the ICU, if someone's very, very sleepy and not breathing well, or their lungs aren't working well because they've got extra fluid in there. Up until about 15 years ago, we just put a breathing tube in them and put them on the life support breathing machines. Now we can actually do it what we call non-invasively. So instead of putting a tube in their throat down to their lungs, we can put a mask on. So there are times where people come to the hospital in the ICU and they're very sick, and we don't necessarily need to do the full life support with putting tubes in people. We can get by with some masks. And during COVID, we learned that there's this thing called OptiFlow, or heated high flow oxygen. It's a little thing that goes under your nose, so you can still eat, you can still sit in a chair, and it blows just huge amounts of oxygen. There's a little damper on it, so it doesn't feel like it's blowing your nose off. And again, it provides so much support that sometimes we can avoid putting breathing tubes in people. And there can be options of, if I get really sick, I don't want a breathing tube, but you know what? I'm willing to try some of these other things. So there's lots of options out there that don't necessarily entail being stuck on a breathing machine or an invasive breathing machine. Mechanical ventilation is what we call it. So usually for this mechanical ventilation, and the traditional way of doing this is people are given a medicine to kind of be put to sleep. Similar to when you go into the operating room for a surgery, they put a breathing tube in your lungs and hook you up to a machine that does the breathing for you. So that was initially designed for operating rooms. And we found that if someone's horribly sick, we can put a breathing tube in someone's lungs and they can stay on that machine for weeks and weeks. You can't really talk very well because the tube is going between your vocal cords, and it's not always the most comfortable. So we typically keep people sedated. After about 10 days of a tube in the mouth, 10 days to 2 weeks, if you're not quite ready to have that tube taken out because your lungs haven't recovered enough, they can talk about changing from a tube in the mouth to a tracheostomy. And a tracheostomy is a surgical procedure where they put the breathing tube in your neck. Sounds kind of horrific. It's actually more comfortable, so I've been told, more comfortable than the tube in the mouth, because you no longer have something sitting on your tongue. There's a lot of nerves in the mouth. There's really strong gag reflexes in most people. With the tube in the neck, you bypass all of that. And sometimes the tracheostomy is done as a long-term solution. If someone has a bad cancer in the back of the mouth and there's a cancer that's blocking the airway, you can bypass all of that. Or if someone has a cancer cut out of the mouth, people can live for decades with a tracheostomy. They can put little valves on it so people can speak with a tracheostomy. So it's not necessarily the worst thing ever. But if it's a critical illness that makes someone sick and their lungs are taking a long, long time to heal and their brain isn't working at all, tracheostomy is maybe not the right solution. So again, it's not a one size fits all. It can be fantastic, but it may just delay the dying process as well. Oftentimes, particularly for COVID, we would have the breathing tube in someone's mouth going down to their lungs, and we'd turn them on their front. You've actually got more lung towards your back. And we found if we prone people, which you may have even heard about on television, if we prone people or turn them on their front, you can actually get better oxygen in them. So sometimes it's not only the breathing tube being in, but we roll people on their belly for 16 to 18 hours a day. We can't keep them face down forever, or else you get pressure sores on your face, which is something we try very hard to avoid. Any questions about the breathing support things? Or any experiences with that? If anyone in the room has had surgery before, most surgeries are done with a breathing tube in the mouth. It lasts for a few hours. Or if you've been in the ICU before, clearly if you were on a breathing machine, you got better because you're sitting with us today. So it's not a death sentence by any means.
Yes, we do have a hand going up here.
I only had this experience with a family member, but I feel like I've heard about it. And I'm not sure if I saw you're gonna cover some risks. But with intubation and it going between the vocal cords, I feel like I hear about people then having problems with swallowing, which then lead to more problems after they're extubated. Is that common, or have I just had a bad sampling of hearing those stories?
So that it can be common. It's the tube sits right between the vocal cords, and sometimes people have difficulty speaking, especially for the first day or two. The vocal cords that you've now put a tube in and kind of stented it open, if that tube is in there for a long time, the vocal cords can actually get a little deformed, and then you can't speak as well. As far as the swallowing, you've got an extra thing in the back of your mouth sitting there for days to weeks, and you're not swallowing because we don't give people food in the mouth when they're on a breathing machine. So a lot of the coordination there's actually a lot of muscles involved in swallowing that we don't have to think about, but if you don't use it, you lose it. So that coordination and ability to swallow does get quite hampered if you're not practicing swallowing for a time. So what we find is after the breathing tube comes out, if it's been in for a long time, there is a fairly high risk of aspiration, which is when people start eating through the mouth again. Sometimes little bits of food, despite their best efforts, little bits of food get into the lungs. And when you've just come off a breathing machine because your lungs weren't working and now you're getting chunks of food and saliva, one of the purposes of saliva is to digest food, or to start digesting food. And when you're getting that right into your lungs, it's a little bit of a setback for the lungs. So kind of risks of intubation are certainly, if you survive to getting the breathing tube taken out, it does make it a little more difficult to swallow. One of the other big risks with intubation is your mouth and your epiglottis and your vocal cords and all these things that are designed to protect you and keep bacteria out of your body. When you have a breathing tube, it's like a highway directly into your lungs. So sometimes bacteria can set up shop in your lungs. And if you already have a pneumonia, or you have, say, heart failure, water on the lungs kind of thing, now you've got a highway for bacteria to potentially get in there. And the hospitals do everything we can to avoid that, but you're bypassing your own body's defenses. So if some bacteria gets in the lungs, bacteria love the lungs. There's oxygen, there's lots of blood flow, there's plenty of food for bacteria, so you can get a ventilator-associated pneumonia. So things that we do to try to give people longer life, sometimes it actually creates more problems. So any one of these things that we're talking about certainly have risks for the lungs, or for really kind of any of the other things that we're talking about. Very good comment, though. As far as the heart support or life support for the heart, we have medicines we can give. We can give adrenaline or epinephrine. It's the same thing, just different names. In medicine, we like to have a few names for things so that we can make it sound like we know what we're talking about. Other medicines right here mentioned are norepinephrine, vasopressin. Again, don't get lost in the weeds, but these are medicines that basically squeeze your blood vessels, and they cause the blood out towards your fingers and your toes. They don't supply as much blood out to your fingers and your toes because it shunts the blood to more important things like your heart itself, or your lungs, or your liver, or your brain. So it diverts the blood to the more important parts. And if you have very, very low blood pressure, some of the medicines, they may cause extremities like the hands and the legs to get even colder because it's trying to conserve that blood for the more important organs of the body. And things like epinephrine, your body makes its own epinephrine, but we just give extra epinephrine. So epinephrine is kind of the hormone that's secreted if you see a bear. They call it the fight or flight response. So epinephrine, if you see that bear, comes out of your body, or your body is stimulating it. And if you see a bear, you either want to fight the bear or you want to run away from the bear. So it's going to increase your heart rate. It's going to make your vision a little bit better. It's going to increase blood flow and how well your heart is squeezing, not just how fast it's going, but how strong it's squeezing, so that you can get that blood out to your muscles to either fight off the bear or run away from the bear. It also makes you breathe faster. So all of these things, if you're laying in an ICU bed, not being chased by a bear, but I'm trying to maintain a blood pressure, I can artificially stimulate your body to have that almost panic response to increase that blood pressure, increase your heart rate. So there's medicines we can give you to, stimulate your body's own processes. Other things that we can do are there's medicines besides the epinephrine, things like dobutamine or milrinone, and they don't really increase the blood pressure directly. What they do is they just make your heart squeeze a lot harder. So even if it's not increasing your blood pressure, it's helping push the blood around the body. The problem with those medicines is they can cause your heart to get a little irritable, like it's poking your heart a little bit. So that can actually cause electrical problems in your heart. So every medicine we give can have some unfortunate side effects, but these are all done very closely monitored. And that's why we do these in the ICU rather than on the hospital floors, is we can adjust these things. And it's really the difference between an ICU room and a regular hospital room it's really the nurses. So in a regular hospital floor, it's typically one nurse taking care of 5, 6, 7 patients sometimes. In the ICU, it usually caps out one nurse taking care of 2 patients. Or for some patients that are very sick, it'll be one nurse taking care of 1 patient. The doctors, we come and go and we see the patients, but the nurses are in the room the whole time, and the nurses can jump on things instantly, and they can adjust these medicines, and they can adjust things much more closely than a nurse on the floor that's also taking care of 5 or 6 or 7 other patients. And the nurses in the ICU are just much cooler, I think, too. I work with them other things, if the medicines aren't working to help support the heart, there's things like an intra-aortic balloon pump. So it's basically a balloon, just as the name says. It's a balloon that goes in usually through the leg, and it times things so that when the heart is relaxing, this balloon inflates. And when you have a balloon that very suddenly pops open, all the blood that's kind of around that balloon, it sits in your aorta, your big blood vessel. Every time that balloon inflates, it displaces the blood because now the balloon is smushing it out of the way. And that actually helps mechanically circulate blood in your body. There's other things called impellas. Has anyone had a fish tank before? Those little pumps that they have? This impella device is essentially like a fish tank pump where it just circulates blood in your body. It's a little motor inside the body that can help support. It can't entirely replace the function of the heart, but it can help. sort of the most ultimate mechanical circulatory support, and a lot of people heard about this during the COVID pandemic, was ECMO, extracorporeal membrane oxygenation. What this is it takes blood out of the body and then it bubbles oxygen into it. So now you've got oxygen in the blood, and then there's a pump that squeezes it back into the body. And that can actually replace both the heart and the lungs short term, not forever. Again, this is designed to buy time for the heart and the lungs to recover. Or in some cases, this ECMO can be used as a bridge to transplanting the heart and the lungs that are healthy into the patient who's so sick. So again, all of these things we do, they're designed as short-term destinations, not a long-term destination. This is a picture of someone on an ECMO circuit. These aren't any of my patients particularly, because I'd get in trouble for that. These are just ones I stole off the internet. But taking the blood out of the body, oxygenating it, putting it through some pumps to squeeze it back into the body. So temporarily replacing the functions of the body. If someone's kidneys, we'll talk about this in another slide or two, but if someone's kidneys are shutting down, they can actually daisy chain in a dialysis machine too. So you can replace the heart, the lungs, the kidneys. There's a little black box over this person's face, but they're also on a breathing machine as well. So lots and lots of things we can do, but they're all on a temporary time frame in the ICU. As far as kidneys, probably many of you know people that are on dialysis, and they go into dialysis a few days a week, and dialysis takes the blood from the body, puts it through a filter, takes out some of the toxins the body builds up, and sometimes takes out some of the extra fluid from the body. And long term, people can live on dialysis for a long time. If someone comes to the ICU and they're horribly sick and their kidneys shut down, we can start dialysis in the ICU. And typically we do something a little different than the regular kind of dialysis. We do something called CVVH. Again, lots of acronyms and lots of fancy words for it's going to be short-term dialysis. The typical dialysis machines that people use if they go 3 days a week, it takes a lot of blood out of the body at the same time, and it filters it and pumps it back in. So if someone has very, very low blood pressure, if I take a lot of blood from the body to run through a filter, that's going to make their blood pressure even lower. So in the ICU, rather than 2 or 3 hours on the dialysis machine, we'll usually run it kind of continuously for 24, 48, 72 hours, where it takes a little bit of blood and runs it through a filter, and we can take out a little extra water from the blood if we need to. They just do that continuously, but same type of concept, taking the blood from the body, running it through a filter, and then putting it back into the body. A little bit smaller tubes than the garden hoses that are here for the ECMO. This is a CVVH machine, one of the continuous dialysis machines. Takes blood typically from a cannula that goes in the neck or the leg, can take the blood out, put it through the machine, and then put the cleaner blood back into the body. Again, this is to replace the kidneys function. Any questions about any of these life support things?
I'm sorry, I have a question again.
Yes, absolutely.
I'm thinking about what we talked about not at the very beginning, Eric, you said like maybe your decision is not to have any of this done. So Dr. Schlichting, my question is sort of like, I know it's going to be different for every situation, but like in general, are you able to give in your experience about how long does a family have to make these decisions about whether to do an intubation, put someone on ECMO, put someone on dialysis? I mean, I know it's different for every treatment. You know, I've been in healthcare my whole life, but like not at the bedside. So like that experience, from your experience, like how fast are people having to make these decisions, whether or not to initiate treatment?
I think it's very dependent on the patient and what brings them into the hospital. Sometimes if someone, has a bad infection and their kidneys shut down and their toxins are are super high, particularly things like their potassium level. Potassium can be very toxic to the heart and cause the heart to stop. So if someone feels ill for a few days, comes to the emergency room and they get some labs and it shows their potassium level is 12 or 15, you know, that could be within minutes of them dying. So the sooner these things are started, the better. And now if someone is 20 years old and all of a sudden we don't know why it happened, but their kidneys are shutting down, absolutely start the dialysis. If someone is 100 years old and they have many underlying problems, maybe that's a time to not jump into these therapies. So that's for the kidneys, for the lungs. Unfortunately, we oftentimes try to skate by without putting a breathing tube in. So we're going to try those non-invasive things, the masks and the high flow oxygen, and watching someone's lungs are getting a little bit worse. We probably need to move towards putting that breathing tube in. And that's really the time that the medical team should be talking with people's families about, is this the right thing for this person laying in front of us now?
So if I
Again, oh, go ahead.
So if I have a piece of paper that says, you know, I want this initiated, I would never want this initiated, etc. I guess my thing is like, there's a time sensitive moment there where maybe you're trying to call family, maybe you're like, how do you know whether or not that person has made their wishes known? Like, if that paper is in my safe at home, like, you as a doctor, like, what's your situation there? What do you need people to do so that you can know their decisions?
So let me jump in just for a moment.
Oh, are we gonna get there? I'm sorry.
We're gonna get there to, you know, kind of where do you keep these things?
Oh, okay.
We will get
Absolutely,
there.
yeah.
And correct me if I'm wrong, but your paramedics and your emergency room people, their default setting is life over limb.
Yeah.
Like whatever they have to do to keep someone alive.
Yeah.
Unless,
And that's my issue.
right, unless right when the paramedics get there or right when they arrive at the emergency department, there's either paperwork or you know, somebody who has the authority to make the call and say, you know, I don't want to start X. But if you're by yourself, something happens, the paramedics show up, they don't have any leeway. Like they do everything to get you. But if it's at your home, yeah, there are places, depending on what town you live in, like they will go and check the refrigerator for medication or whatever.
Okay.
We'll get to that in a little bit. And he said,
Thank
having
you.
it in your safe, do not put these things in your
No.
safe deposit box.
No.
Yep.
They are designed to be hard to get into. But yeah, we'll touch on that. One of us will.
Yes, absolutely. But I think that's actually kind of a perfect segue, and we are very much going to circle back to that. How can you say, maybe I don't want that? Sort of the ultimate life support. And the reason we talked about lung support and blood pressure and heart support and then kidney support is, I don't have a lot of other organ systems I can support. If someone's liver is shutting down, there aren't really effective ways to do liver dialysis. There's a few machines that kind of help out with that, but we can't replace the function of the liver very well. We can't replace the function of, certainly, most importantly, we can't replace the function of the brain. We can give medicine so people don't have seizures, but I don't have a lot of things I can do that really help replace the function of the brain. So that's why we didn't talk about support for the brain, because it's supporting everything else to keep good blood flow and good oxygen to the brain, but we can't really replace that function. The ultimate life support is CPR, cardiopulmonary resuscitation. Many of you have probably learned CPR. I teach CPR. It's some really fantastic stuff. It's sort of full court press here. So that would usually entail a breathing tube going in to support the lungs, giving medicines, giving the chest compressions that help circulate the blood. If someone's heart is having irregular beats, sometimes using shocks or defibrillation to sort of What that electricity does is actually causes the heart to stop transiently with the hope that it starts up again at a normal rate. So this is lots and lots of stuff that happens very suddenly. The typical default medical care, whether someone's in the hospital or someone's at home, if 911 is called or if in the hospital a code is called, everyone's going to show up. If they see a do not resuscitate bracelet on someone, or they see the documentation that, nope, this is a do not resuscitate person, then they focus on comfort. But unless those things are in place and very easily found, or it's identified very, very quickly that no, they don't want to be resuscitated, everything's going to get started. And it happens very quickly. A lot of people, this is whether it's a 2-year-old in the hospital or at home or a 102-year-old. This can be someone in perfect health or someone that's in a nursing home that's entirely dependent on others for their care. There are a few exceptions to that. If someone is decapitated, or if someone has, transection where their, chest is cut apart from their abdomen, that's not things that people can survive. But by and large, if someone is found down, unless they have a bracelet on or paperwork very close by, they're going to get everything done. So the full code would be the CPR and the medicines and the breathing tube put in. Most of the time, people don't perk up very quickly from that. So if a heart is started again, then they keep going down that pathway of, now we're going to start some dialysis if the kidneys shut down. We're going to put in a feeding tube because people need calories for the body to heal. So it's a very rapid progression of things that can happen. It can be some CPR is done, you get a heartbeat back, and then they're able to reach family. And depending on the discussions that have been held with family before, family may say, well, this person says do everything and this other person says do nothing. And then there's a lot of conflict that can come up. So if there's conflict, by default, we kind of continue going down the slippery road of we're going to keep doing everything to try to restore them to health. Sometimes if someone has advanced cancer or advanced dementia, we can't restore them to health. Doing CPR is not going to cure cancer, unfortunately. It may delay things a little bit, but some of these are maybe roads that people don't want to go down at the end of their life.
Let me jump in.
Yeah,
Let me jump in for just a
we
moment
need to
here
discuss
before
these
we.
things.
Yeah, I'm gonna bring it back to my wheelhouse for a minute here. So just by a show of hands, and you don't have to explain the circumstances, but and I know a few of you in the healthcare end of things have mentioned this to me, but has anyone here been present when that conflict has happened, or maybe you have been a part of that? So I'm seeing a lot of hands go up around the table that something happens and people are in the emergency department, they're in the hospital room, and people start fighting over what to do. So
And it has to happen so fast. That's why I asked that question, because speed is not a good decision maker.
Right. But you can have the discussions and make the decisions ahead of time.
Yes.
And again, like we said, and I think we'll touch on this too, it's an ongoing conversation. The things that I would choose for myself are probably different now than they will be
40 years
when I am older. So yeah, but again, yeah, that's so folks who have been there and seen that, and Adam, feel free to jump in on this. I'm gonna guess it's not the sort of thing you want to be going on around you. Is that fair to say? If there's a way you could avoid people.
I think sometimes, first of all, so Adam, I spent probably 10 years at the bedside, and then I was an even cooler nurse in the ER for 20 years. And then I have some advanced practice with diabetes. So I have a lot of history. I think in the ER part, when it's a sudden decision, people start to feel guilty. And that guilt probably plays a big role in, and one kid is guilty and one kid isn't guilty, and the fight ensues. But if people have that discussion ahead of time and say, I really want quality of life over quantity. If I have pneumonia, yeah, help me get better. If something is temporary, and maybe even let people know in a family what is temporary to you. Is that 6 months or 6 weeks or 6 days? You know, and it does, I think you're right. What you choose at 30 is different than what you're going to choose at 80.
Right. Except for the baby boomers, because y'all are going to live forever.
No, we won't.
Unfortunately, Tom isn't here. I really love to push his buttons with that one. Scorched earth generation.
We're
I didn't know
tougher,
you
but
wear a
not.
Bracelet though, that was nice, that was helpful, because obviously I'm very obsessed with like, what if nobody knows what that paper is?
Right.
If I'm on the road and I'm in an emergency room in another state, you know, and
Right.
that's the stuff that really scares me.
Keep it in your wallet.
Or that it exists, even the fact that it exists is probably helpful.
Right.
I don't know whether you have my chart where you're at, Adam, but can your directives be put into my chart if you know?
Yes, they can.
Absolutely.
Yeah, you can upload them now, and only in some hospitals.
Yep. And sort of the timing on things, if someone has do not resuscitate paperwork, or they have advanced directives and the paramedics can't find them or don't know, they'll start full court press and keep doing things aggressively. But if those papers, you know, are found, or someone has time to log into the computer and they see, oh, this person usually gets their care in Illinois, but I see in their computer system that I can hack into, yeah, they have had do not resuscitate paperwork, then they can always stop. Or if in doubt, if there's conflict in the family, I don't know if we'd want this versus not. Sometimes the resuscitation, all of these therapies, we can start them. And then if families change their mind, or if the person wakes up and is able to participate in the conversation, and even if the breathing tube is in their mouth, they can write on a piece of paper, I don't want this. We can always change course. But how much damage has been done? If they've had some CPR, did it break some ribs? Did it cause more pain? Especially if it's something that they didn't want, and now they wake up and they're in an ICU with a lot of tubes in them. Again, they were trying to avoid it, but if in doubt, the medical system and the paramedics are going to legally, they're required to start resuscitating unless there's something to say not to. And specifically for the CPR, sometimes we can temporize if people are having breathing problems, or we can try some medicines and fluids and whatnot if the kidneys aren't working. For the CPR, it's the sooner CPR is started, as I'm sure you all learned in taking CPR classes, if you stand there and you watch for a few minutes, that's all time they're not circulating blood, and their chances of surviving and their chances of their brain working get exponentially less the longer you wait. So the best is as soon as possible, the CPR gets started. And if you can't find paperwork that says don't start, the paramedics and the hospital team are going to start.
Yeah.
Usually in the hospital, those papers should be readily available and everyone should know, but sometimes mistakes happen and CPR is done on people that really didn't want CPR. Examples of CPR. Did anyone hear about Damar Hamlin?
Oh, yeah.
A little over a year ago now, NFL player on the field, and then he dropped dead. So miraculously, he did very well, recovered well. Damar Hamlin is a 24-year-old professional athlete. He is paid close to $1 million a year to stay in top physical shape. He did not have underlying advanced dementia. He did not have underlying metastatic cancer. He did not have, organ failure at his baseline. He was in the peak health he could be in. He's healthier than probably most of us. When he collapsed on the field in front of all those people, he had medical care within 10 seconds of him collapsing. Within about 12 seconds, they were doing CPR. So that is really best case scenario. the depictions of CPR, if you watch television, if you watch Baywatch, 70% of people
I think you just dated yourself there.
Like so many of these television programs showing CPR happening, 70% of those people on TV wake up and they're fine. Oftentimes after a few compressions, they sit up and cough once or twice and say thank you. Not usually the case, unfortunately. When people are surveyed, and these are surveys from the US and other, international surveys, when they survey people, what do you think the effectiveness of CPR is? Most people say they think about 75% of people get better after CPR. Unfortunately, it's more like 10% survive. So it's not good numbers. Survival is also a little bit of a slippery slope there. It may be survival on a breathing machine. It may be survival needing the renal replacement therapy long-term, or living in a long-term acute care hospital, so sort of a fancy nursing home. Maybe not the quality of life that everyone wants. If someone's in the hospital, they're already admitted to the hospital for whatever reason. If someone's in the hospital on the floor and their heart stops, it's about a 25% chance of surviving out of the hospital, to survive to go home from the hospital. If someone's in the ICU and their heart stops, it's an even lower percent, which seems like it wouldn't make sense. You've got a lot more stuff. You've got a lot more attentive nurses in the ICU. It's what brought them into the ICU in the first place. If they're in the ICU because their organs are failing, and then all of a sudden their heart stops on top of that, they have all of the underlying health problems that cause them to be in the ICU. And now on top of that, the cardiac arrest. So even being in the hospital does not keep, good outcome numbers from cardiac arrest. Other concerns after cardiac arrest, whether it happens in the hospital or out of the hospital, are the brain needs a lot of oxygen. The brain is a very busy organ in the body, and it's 2% of the weight of your body, but it gets 20% of your cardiac output. Every time your heart squeezes, 20% of that blood is dedicated to going to the brain. So if someone's heart stops and it's not pumping blood, then that brain that needs blood, it's not getting it very well. Even with the best CPR, you're only getting about 25% of the output of the normal heart function. So 20% of 25% is not a lot. So the brain that needs so much blood flow and so much oxygen is getting very minimal. And if the brain doesn't get what it needs, it gets upset, and the brain can swell. And people can have what we call anoxic brain injury, again, because the brain tissue is so sensitive to low oxygen levels. If you think of taking a rubber band and put it around your finger very tightly, if you leave it on for a while, your finger is going to turn purple. It's going to start swelling up. The brain does that with even shorter durations of time without good blood flow. And when the brain swells, there's not a lot of room for it because it's surrounded by bone. You've got a hole at the bottom, your brain stem. That's the very most important parts of the body that protect the reflexes and things that trigger you to breathe, things that, trigger reflexes. Reflexes are things you don't need to think about. Your brain just does it. If you touch a hot stove, your brain doesn't have to process that and say, this is hot, I should take my hand away. All that time your hand will be cooking on the stove. Instead, with a reflex, you touch something hot and you automatically pull away. Generally, you don't have to think. Take a breath, take a breath, take a breath. Those are all things that the brain automatically does. And those reflexes, they're stored at the brain stem, that very bottom physical part of the brain, right? Kind of where the spinal cord comes out. And those are some of the best protected, best preserved functions of the body. But the problem is if the brain up above starts swelling, and this brain stem that's sitting right towards the bottom of the brain, if the brain swells, it starts to smush those things. So even those reflexes and the ability to breathe can get extinguished, unfortunately. And the longer someone's brain goes without getting oxygen, without getting good blood flow to it, the higher the chances of the swelling of the brain. So that's the brain. Other things that can happen after CPR is people can have broken ribs. Effective CPR generally does break some ribs, or at least the cartilage that connects kind of the breastbone with the ribs. So there can be some pain associated with that. If people aren't waking up, perhaps a tracheostomy or staying on a ventilator long time, or will people need feeding tubes? Will there be, horrible debility? And again, a lot of these choices can't be made by the person who's laying in the bed who just had CPR. It falls on their loved ones to decide, well, they said they wanted full resuscitation, but did they want to stay on a machine long term? All the more reason discussing these things with your loved ones is so important. So CPR, there's lots of bad things that can happen from it. Should we do it at all? Absolutely. I think Damar Hamlin would say yes. I think the 10% of survivors from out of hospital cardiac arrest would say, yes, please try. But again, that's given in the context of someone who's relatively healthy or very healthy. There are things we can do, but maybe that's not right for everyone. And everyone's situation, as their life evolves, things change. So it's a dynamic process. All right, are we depressed yet? Not trying to depress anyone.
Yes.
Yes.
Lots of things we can do, but not necessarily always should. And if you sort of know things can play out well or things may not play out well, it's a bit of a gamble. And trying to write down on a piece of paper exactly what you want or don't want, these are all moving targets. So this is not easy by any means. And I think knowing that it's not a static decision is important too. But some of the other very important aspects are quality of life. What is the quality of life that you're going for? If you think I would never want to live with, other people needing to feed me or other people needing to bathe me, or if I'm stuck on a breathing machine, or if I'm in a persistent all of these things that you may not wish to have. That's also while you're sitting in a room communicating with people. So as you get a little bit older, as you get some health concerns, maybe it's not so bad if I need a little help eating. I need someone to cut my food for me. So again, making a choice right now does not mean it's the choice you need to stick with. Maybe it's okay if someone gives me a bath. Knowing that right now your choice does not need to be the same as it will be 10 years from now. Again, it makes these decisions sometimes even a little harder. This is not an easy topic.
Let me jump in there briefly. And I'm gonna point this out. This is on your handout. But yeah, the choice you make now versus the choice you would make down the road. One of the things I've heard, again, yeah, revisit these things. Don't make them don't make them today. Well, yeah, put these things together today, but then don't put them on the shelf and forget about them. The 5 Ds, check them every decade. When there's a divorce, if you are separating from your spouse, there is a good chance you do not want that person making healthcare decisions for you. Or maybe you do, but you want to revisit it. When there's a major diagnosis, you are diagnosed with stage 4 pancreatic cancer. That will be a time to revisit these. The death of someone close to you often is a time when people kind of reflect on these things. Pull out your directives and look at them. If there is a decline in your health, so other than a major diagnosis, if there's something happening, there's 5.5 Ds from what people have told me. An onset of dementia. You could possibly have a limited amount of time when medical and legal people would be able to say, yeah, the person made these decisions when they were still of sound mind. So it's something that you would want to go after it in an expedited fashion. But yeah, don't. Yeah, let me be clear. Yeah, fill all of these things out as soon as you are ready to do so. But then don't throw them on the shelf, throw them in the freezer or refrigerator. We'll talk about places to put them, and forget about them. Keep them updated. Keep them reflective of what your circumstances are.
Don't set it and forget it.
It's good for your instant pot, not for your.
And that makes it easier to make a decision too. I like that Dr. Schlichting is saying, like, you can always revisit this.
Mhm.
As long as you're.
Absolutely.
Okay. I mean, that makes it easier to just, when I did my first ones, it made it so much easier to do that. Because it was, oh, I'm just deciding for now.
Right. Yep.
Exactly. And as people may accrue more unfortunate diagnoses, revisiting these things, something like ALS or Lou Gehrig disease. Stephen Hawking was diagnosed with that in the late 1960s, and he died in 2016, I think. So you can live a long time with some of these diseases. But if things are becoming worse and you feel that your quality of life is not good, you can always refocus at that point, with the exception, as Eric mentioned, of with more progressive dementia, it's more difficult to have a cogent conversation with someone about end of life care if they're not able to participate in that conversation. Other things, I think we're starting to run a little short on time here, so I don't want to keep everyone for too long, but we'll skip through some of these slides a little quickly. Palliative care is focusing on managing symptoms of a process. It does not exclude active treatment, and there's actually some very nice research that's been done. People diagnosed with advanced cancer who also have palliative care involved. So the palliative care team focuses on their symptoms so that they're not throwing up, so they're not having pain. And the cancer team is focused on treating the cancer. Those people have actually better quality of life. They live longer and overall feel better about their care if they also have a team that's focused on just treating their symptoms. So palliative care does not necessarily mean it's the end and we're not going to do anything. It focuses on just treating symptoms and treatments for other things in the background. Similar is hospice, but that's rather than focusing on, we're going to try to fix this cancer, we're going to try to fix this, very bad heart failure. It's, we're not going to worry about those numbers anymore. Or if someone's in the hospital or in the ICU, rather than me focusing on the numbers up on their monitor, what their oxygen level is, what their heart rate is, I don't worry about those numbers anymore. I look at the person in the bed and go, John, are you comfortable? You're not comfortable. I'm going to give a little more pain medication. So hospice is entirely focused on symptom management and not necessarily doing all the things with the plan of let's try to make you live as long as possible. It's for the time you have left, we're going to focus on keeping you comfortable. And there can be hospice facilities, hospice in the home, or we can do hospice in the hospital, in the ICU even. If a family makes a choice, let's take the breathing tube out. This is not what she'd want. We can do very similar to hospice care in the ICU even. So importantly, and this is large, I was given a lot of the background of some of the things we can do in the ICU and the things that medicine can do. But importantly, the reason for today's talk is how can you help determine your destiny there? So please make your own choices. And then once you've decided what's best for you now, revisit that and have active discussions with your loved ones. Again, it's so frequent that if people have not discussed this, if someone's not able to make a choice of what they want, it falls on their loved ones to make choices. And not everyone agrees what should be done. One sibling may say, do absolutely everything to give them longer time alive. And the other sibling may say, no, I think they've had a good life. They're ready to go. That just creates conflict. For yourself, it gives you a little more control. Towards the end of life, you lose control of a lot of things. This gives you control as to determining your own destiny to an extent. And I liken it to when God calls, getting CPR is not, maybe it's going to delay that slightly, but we all know everyone will die from something. So it gives you control to say, I don't want that towards the end of my life. If I go out quickly, great, just let me go. Or if you want everything done, but you can determine that and you can explain that to others. Now specific to Indiana, and I think there may be copies of this that Eric handed out, but
Yes,
there's
hold
lots
on.
of different forms that can be filled out. The Indiana out of hospital do not resuscitate order. This is a doctor needs to sign the form. This is actually the form here. It's a one-page document. Your doctor signs it. It requires that you have a terminal condition, which is a little loosey-goosey term, but your doctor has to say it's something that you won't get better from. So you need a terminal condition for that one, and you need a doctor's signature. The next one is many states have a post form or a post form, which is the physician order for scope of treatment. Again, physician order, you need your doctor to fill out this form with you that says, if my heart stops, I want, yes, CPR or no CPR. I want life support. You can sort of specify things that you want.
Let me just, I thought I had the DNR paper. I do not, but I can print those up. I can get those for you today before people leave. But the Indiana Post form is going around now.
So this is very much a checkbox. I want this. I don't want this. Again, when most people are filling this out, they're sitting there in relative health. So these things can be revisited at any time. If your health declines and you say, you know what, I don't want that anymore, or you know what, I'm actually doing pretty well. Someone helps me eat, but I'm doing pretty well. Actually, I want that nutrition support. You can change these things around. So these, again, they're physician orders, so you need to talk with your doctor about it. And I would probably suggest, as you're filling these things out, take a copy or two with you to the doctor, kind of check down what you think you want, discuss it with your primary care physician, because they know you, they know your health, and they may say, I completely agree, or you know what, maybe try this for a time, but have a discussion with family, with your healthcare providers. I think it's very helpful. That post form, it's a little bit of a smorgasbord. You can sort of, there is that section D for optional orders. I have seen some crazy things in there. People that only want drugs that start with A. People that only want chest compressions with someone's left hand. So you can get very nitty-gritty with these things, but it's designed for a purpose. When you get a little too creative, it somewhat diminishes the value of the form. So don't get too creative. The do not resuscitate form, it's not so much a yes, no form. It's if that form is filled out, it's saying, I do not want CPR, period. It's not yes, I want, no, I don't want. If that form is filled out, it's I do not want CPR. Again, the post form gives a little more, yes, I want this, no, I don't want this, where you can make a few more choices there. But mostly they're binary choices. Yes, I want, or no, I don't want. And clearly your health and all of the different things, it doesn't say anywhere on that post form, I want ECMO cannulation, I want dialysis. So there's so many other choices that could need to be discussed that don't fit neatly in a form. If a new therapy has come up with next month that everyone starts using, it's not going to be on the form you filled out 2 years ago. So you can never have every permutation figured out. And that's why you need to discuss with families. Let's see. There we go. 60 to 70% of people in the ICU, unfortunately, cannot have these conversations, either because a breathing tube is in their lungs or their brain isn't working well enough. So again, even if they fill out that post form perfectly for them, That's in the context of they're sitting there awake, filling out a form, but now they can't decide if they want the ECMO cannulation, or they can't decide if they want the dialysis or not because they can't participate in that conversation. This is why you need your family and your loved ones to know what you want, what you don't want, those sorts of things. And if you don't discuss specifically, I would never want ECMO cannulation, I would never want X, Y, or Z therapy, you probably can't discuss every single permutation. And again, it would be in the context of, well, you're healthy enough to have that conversation. So someone that knows how you think is who you want to be making your decisions. So if you can't make your decision, who decides for you? In Indiana, it's actually spelled out pretty clearly who can make these decisions for you. If you have a form filled out, and we're going to talk about this form in just a minute, if you have a form filled out, your designated agent is the person who makes these decisions for you. If you don't have a form, then it goes in a very specific legal order of all these people that are listed.
Forms.
So yeah, fill out forms. It could be a court-appointed person. Next would be your spouse. Next would be an adult child. It doesn't say which child. If you have 2 children, if you have 7 children, the law does not say which child gets to make the decision. So right there, you may be creating a little bit of conflict by not designating someone as to which child you want making that decision, or maybe you don't want any of your children making the decision.
We have a question.
Yes.
Are these state specific? For example, we lived in Ohio till 6 years ago and made papers in Ohio. Are they still applicable to Indiana, or do we have to do an Indiana form?
You have to redo it.
You have to redo it?
So it's a little bit of a sticky situation. If you have a form that's filled out in Indiana and you're visiting Michigan and something happens, if you have that form, most of the time legally and the hospital, care is going to say, oh, you have a form, even though it's from another state, you have said, I want this person to make my choices for me. If you've designated it in advance, most of the time those forms are going to be respected. The bigger problem is if you have not designated anyone to make your choices for you. In Wisconsin, this decreasing order of priority, first the judicially appointed person, then a spouse, then an adult child. Other states don't have this exact framework. In Wisconsin, for example, if someone does not have power of attorney for healthcare paperwork designated before they get sick, then it goes to the Wisconsin law, which is, well, everyone needs to have consensus. You imagine everyone and think of your own. Can everyone in your own family have consensus on anything? What should we watch on TV right now? So having consensus on something that's much more meaningful is very difficult. And when we don't have consensus, then we oftentimes need to drag it out for a long time until consensus is gained, or sometimes the body decides on its own. So having this paperwork in advance is so important. And again, if you travel outside of Indiana, if you have the paperwork at home, if all the things get started and the CPR while you're out of state potentially, if someone brings the paperwork even from Indiana, it will probably be respected that you have designated before you got sick, I want this person to make my choices. That's not 100% guarantee though. But realistically, filling out a form to every state you go to and having it signed by a physician and having it, notarized, I think most states recognize that's not feasible. But having these conversations is so important. Excellent question, though. So how do I decide who I want to be? I just mentioned it's so important to have someone designated as your agent. How do I decide who I want to be my designee? Think about your family. Who would you not want making choices about you? Think about your friends. Maybe having a spouse make this decision, they could be too emotionally connected. So it's not the easiest decision to make. but you can fill out this one page. There's a few versions of this. This is the Indiana specific one. Again, it's a one-page version that says, if I can't make my own medical choices, I want so-and-so to decide for me. And if they can't do it because maybe they're in the same car accident with me, or maybe they're, you know, they say, I can't choose right now, then you put your backup on there as well. So all you need is you put down 2 names. Please tell them that you want them to make choices for you. Don't make it a surprise. And then you have 2 other people, not the witness or not the representatives, but 2 other people sign it. I would guess Eric would be willing to be one of those signers, or you could have a notary sign it. And if at any point, let's say you put your spouse and you get divorced, if at any point you want to revoke that decision, you just sign the form. You don't need a witness anymore. You sign the form that says, I don't want them to make my choices for me. But then please fill out another form. So you can very easily dictate who you want to make decisions for you if you can't make your own decisions. Indiana also has another version of that form. Exact same choices. You put your name, you put the names of 2 other people, and then you can dictate a little bit. You can circle, I value the quality of my life. If it's not going to be a good quality of life, and again, you can't define that in too much detail on this form, but I value quantity over quality. You can direct your healthcare decision makers a little bit in that direction. Again, hopefully you've had these conversations with them as well. So exact same form with just an extra little section on, I prefer this over this, but in broad strokes. Again, the people that should be making your choices for you are people that know you well. They know how you think, they know what your values are. Someone who truly cares about your well-being. And again, someone who is capable of making very, very difficult decisions. These are permanent decisions. If it's a spouse, that can work very well sometimes, or maybe not. But if you are married and you designate someone else as your decision maker, please share that with your spouse. There are a lot of surprises that come up when, you know, a spouse comes to the ICU and says, this is what I want to do. And we take out the piece of paper that says, well, they don't want you making their choices. These are discussions that hopefully don't need to get settled in the ICU. As you're choosing people to make decisions, don't list your physician. Physician, if they're a personal friend, not that they can't be a physician, but generally don't list your own personal physician as your decision maker. They should help you make decisions. They should help guide, but it's sort of a conflict of interest if they're the one that's deciding ultimately. Please get their advice, but they shouldn't be the decision maker entirely. Other conflict of interest situations, if it's a nursing home administrator that, you know, could potentially gain money by keeping you alive longer, or if it's a funeral home director that could potentially gain money by you expiring a little more quickly, just think through those things, who you're choosing. You don't want them to have secondary gain unless they're a personal friend on the side. Flipping the situation, if you have been designated as someone's decider, they ask you to do this because they trust you and they've documented, hopefully they've documented what they want, at least as far as broad spectrum things. I want CPR, I don't want CPR, I would want to be on a breathing machine for a time, or I wouldn't want that. But what you're doing is you're being their voice. Whether they've told you exactly or they've written down exactly or not. Again, there's so many permutations that you never discussed. But in general, if they were being asked the question by the doctor, would you want this versus not? What would that patient laying in the bed say? And when they can't say it, you having known them for 10, 15, 20, 25 years, you know much more their thought process than the doctor who met them, 2 hours ago. When these questions are asked of you, you're not saying this is what I think is right for them. It's this is what John would want. So you are being their voice and letting the doctors enact what they would have said. If the person has previously said, I want them to do everything, I want them to try everything, again, that's when they were having a conversation with you. You kind of need to take in context if they've had a horrible, horrible brain injury and they're going to be stuck on that machine forever. Or the doctors are saying, we think their chances of waking up are less than 1%. Is that the gamble that the patient would want to take? So again, so many dynamic processes that other people need to make decisions on. Oftentimes, as we're having these discussions with families and decision makers, people will say, I don't want to be selfish, but I can't let him go. Please try to somewhat remove yourself from the situation. Again, your job and what that person laying in the bed asked you to do was decide what's best for them, not what's best for you. Of course, if someone dies, you're going to miss them. It's going to leave a void, but don't make the choice for their life or their death based on the void it'll leave for you, as hard as that is. We'll oftentimes hear, he's a fighter, do everything. But again, in the context of what are we fighting for? If someone is horribly, horribly sick and they're suffering every breath they take, is that a fight that they want to continue making? These are a lot of downers, I know. I do these conversations every day, unfortunately. So my final thoughts as a critical care physician myself, these forms are not, as Eric mentioned, the 5 Ds. Every decade, when there's a divorce, when there's a new diagnosis, particularly with dementia, if someone near and dear to you dies, maybe reconsider what you want for yourself. Or if you have a decline in your health, your mobility has gone down and you feel socially isolated and your quality of life is maybe not where you feel it should be. Perhaps if your heart stops doing all the resuscitation and being on the machines, maybe that's not right for you at a given point in life. These are not set it and forget it forms. Fill out the forms. More importantly, have the conversations with people about what you think is a good quality of life or maybe what you wouldn't want. And again, these forms can be revised. So my general suggestions, I think, if you're pretty healthy at baseline, just like the Damar Hamlin example, a few minutes of CPR to see if you get better. A few shocks of the heart, a few days on the breathing machine, a few days of antibiotics and such. I think those are incredibly important. They buy time, and that's time for the body to try to heal. And if you see after a few days that things are not getting better or if things are getting worse, maybe that's your body showing, okay, the body's going to make the decision on its own. So time-limited trials of things, I think, are very reasonable. Very importantly, trust your medical team. And if you don't trust your doctor or you don't trust the critical care team, always ask for a second opinion. Could I have another doctor come in and help confirm that? These are sometimes very final decisions. So having a second opinion, and again, doctors should not take offense if you ask for a second opinion. Having someone else come and take a look at all the data points to say, yes, I agree with the other doctor. Things do not look very good. They're final-ish decisions, so getting a second opinion is not a problem. If, on the other hand, you have someone that has very advanced disease or they're very ill at their baseline, maybe making some of those decisions of, if my heart stops and God calls, it's my time to go. If my body gives out, just let it go. Maybe don't put me on a breathing machine long term, or maybe not at all. You can try that BiPAP mask or that CPAP mask, but I don't really want a tube in my mouth. If I leave this earth, I want to leave the earth like I came into it, without plastic tubes in me. Sure, give me some fluids, give me some antibiotics, but I don't want to be stuck on machines, taking the blood out of my body. Let me go comfortably. And again, when God decides it's time, it's not the doctors that decide. It's not you as their healthcare power of attorney that decide. It's really God that decides when it's time. Some of the other things, all of the critical care that we do, all of the CPR, those sometimes delay a little bit when someone dies, whether that's for a few minutes or that's for a few decades. It's just a little delay of game there. And advanced age, I think, factors into this as well. Even if someone is a perfectly healthy 105-year-old, so someone who is 105 at the time of their birth, they were expected to live about 60 years. So they've already outlived when anyone expected them to survive because of, vaccinations and because of new medical things and whatnot. People are living much longer than anticipated when they were born, but still, a healthy 105-year-old is still working with 105-year-old parts. So as people approach advanced age, and exactly what that definition is, as I get older, I keep pushing it a little further out, but as people age, I think it's important to take that into context. The healing ability as someone ages just declines. One of the final thoughts is if someone's at home and they suddenly have a cardiac arrest episode and then the next day someone finds them, it's not always the worst experience. They went suddenly. There's not decisions that need to be made by family. And again, they're hard decisions. Even if someone has said, I don't want this, that, or the other, the timing of, yes, I think it's time to withdraw life support now. If someone dies at home and they're found down, maybe just staying down and not going through the CPR and the breathing machines is maybe not the worst thing. If it's a witnessed cardiac arrest, Damar Hamlin, for example, yes, try it. But if someone's been laying on the floor for a long time and you don't know if they've been unconscious for a day or two, maybe not being overly aggressive there. But again, that would be dictated by people's choices in advance of, I want CPR, I don't want CPR, so using that post form. And more importantly, by discussing those things with their families and their loved ones. Yes, go ahead.
I got two more pieces of paper coming around. There is a living will declaration for Indiana, and I have a glossary here that has some key terms on it for people.
Do you have any more about the representative designated?
Any more of those forms?
Yes.
There's this one, and I will check and see if it has been updated, because I think what Adam was showing was more recent than that, so.
And do you have extra for that money now?
They should be coming around now. If not, I will have more of them.
Oops, sorry.
I can print more of them, or if you search for these forms online, Indiana
Oh, okay.
has all of them on the internet as well. And that may be a good idea. We'll make sure we got the most updated stuff for folks.
Yeah.
So in the minute or two we have left here. But final points.
Oh, final points for me,
For you,
I
yeah.
think would be, please discuss these things with your family. They're not fun topics to discuss by any means, but it really kind of helps direct the care of yourself and the care of your loved ones. When you can't speak for yourself or when they can't speak for themselves, you're doing what they think is best for their health. Again, everyone's going to die. This is not going to be a surprise, but sort of directing that care, I think, is very helpful. And it's very comforting for loved ones around you to know that they are doing what you wanted. If you value the quantity of your life, you want to live as long as possible, I think that's an option. If you value the quality of your life, these are things you need to discuss. Again, 60 to 70% of people can't say what they want at the time. So discussing before is so important. Oftentimes, as we're having discussions with families, they will be waiting for the miracle. By definition, miracles are not very common things. So when someone is critically ill or their heart is stopped, banking on a miracle is not a good plan. They don't happen very often. So having some plans in place, I think, is vitally important. Again, this is the a very helpful website. This is all the legal forms of end of life and patient preferences in Indiana. So even if the forms that Eric passed out, if they ran out of a few of those copies, all the updated forms are put on this indianapost.org website. This is the forms where you can say your DNR or your post forms, or I think this even has the healthcare power of attorney paperwork. So all of the forms should be on this website. And again, in the words of Eric, Good Friday always comes before Easter. And I think recognizing that, as depressing as it may be, can very much help sort of direct what you want. What questions do you have? Sorry, we ran rather long there.
Let me jump in with something that is in your handout, where to keep copies of these things. Multiple copies somewhere in your house in a safe but accessible location. An additional safe but accessible location. You know, your person who is named in these documents should have copies of them on file with your agent, whether that's healthcare or power of attorney for property. Your doctor, put them into my chart. If you have an attorney you work with their stuff, have them have a copy of it. If you're admitted to a healthcare facility, you know you're going for surgery, give them copies of it. Check with your local fire department. St. John has a Vial of Life program. They will give you a sticker. You put it on the refrigerator, and they will give you a container to put medication lists, doctor's orders, all those things. Contact your local fire department to see what their options are. I know in St. John, they can also give you a lockbox. So we have one out there, a Knox box. If you feel like, yeah, something might happen to me, they can have a key to that Knox box and open it up rather than busting your door down. You can place a card in your wallet by your ID that says where you can find it. And if you're going to do that, have it be very specific. You know, there's a red folder in the cabinet above the stove. So, but yeah, the refrigerator or somewhere very specific, because often first responders will look in the refrigerator for medication. So, yeah, those things, people you want to talk to, let me echo what Adam said. Whoever is going to be potentially making these decisions, talk to them, talk to your physician. If you are in the hospital, talk to your chaplain, talk to your advocate, talk to if there was an ethicist, which they may or may not have because you can't say it. You can talk to your pastor about this too. So have the conversations, please. Questions?
Yes. If you're legal power of attorney for healthcare, at what point does it get activated?
So it's usually activated when, and it may be slightly different in Indiana. I'm not fully certain of how.
This person is in Illinois.
In Illinois, Illinois law and Wisconsin law, I think, are pretty similar to most states. It's pretty similar. If someone can't make decisions on their own, that's where that power of attorney would kind of kick into action. Some states it requires 2 physicians to say, yep, this person can't make choices of their own. Sometimes it's by default. If someone is on a breathing machine and unconscious, it automatically switches over. Exactly when it gets activated is a little bit dependent on the medical team too. So sometimes it takes a little bit of prompting, like, should we activate the healthcare power of attorney now? Like asking the doctor's team. It doesn't seem like grandma can make very good decisions. I'm the healthcare power of attorney. Should I start making decisions? So sometimes it takes a little nudging there.
Okay.
Kind of a wishy-washy answer because it's a wishy-washy subject.
That's about what I expected.
There's no hard and fast rules, unfortunately.
Okay.
Any other questions? And as we said, we hope this is the starting point for conversations. So of course, you know, talk to all the people you need to talk to. So there. Well, thank you so much for your time and for being here with us digitally. Yeah, I'm glad we had a good crowd turnout for this today, and please go ahead and start working on these things. Can we close praying the Lord's Prayer together? Our Father, who art in heaven, hallowed be thy name. Thy kingdom come, thy will be done, on earth as it is in heaven. Give us this day our daily bread, and forgive us our trespasses, as we forgive those who trespass against us. And lead us not into temptation, but deliver us from evil. For thine is the kingdom, and the power, and the glory, forever and ever. Amen. Great, well, thank you. Thank you to everybody for being here, and hope everybody has safe travels on your way home.
Thank you, Doctor.
Thank you, Doctor.
Thank you.
Thank you.
There we go. Let's see.